Good morning, everyone. Welcome to our webinar. Thank you so much for joining us today. I'm Daisy Allington of Cognitant Group, a health technology company based out of Oxford. At Cognitant, we're patient engagement specialists on a mission to empower people with information about their health. One of our focus areas is stroke medicine, which we'll dive into today. In this session, we will ask the question, can digital education help stroke survivors to have better outcomes? I'm delighted to be joined by Dr. Rob Simister, consultant in neurology and stroke medicine at UCLH, and Lee Callahan, stroke survivor and volunteer at the Stroke Association and one of our patient advisors. Next slide, please. And next slide, please. The global burden of stroke is significant, with over 12 million new strokes per year and 100 million living stroke survivors. Sadly, the projections are for these figures to rise, so we urgently need to find new ways to prevent stroke and to support people who suffer stroke. We have created My Stroke Companion, a personalised digital support package of information and resources that stroke survivors and their families receive on discharge from hospital after suffering a stroke. Thank you to our funding body, the Small Business Research Initiative, backed by NHS England, and our clinical partner, University College London Hospitals. We've been able to pilot My Stroke Companion with nearly 500 patients so far and have some key findings to show you today. Next slide, please. We thank all of our incredible partners working with us on this project, many of whom are with us in this session today. Next slide, please. Today we will cover Dr. Simister's view of the challenges for stroke survivors, family members and clinicians. Lee will then provide a unique but sadly not uncommon patient perspective, and we'll talk you through our work so far, our findings and our plans to extend this to all stroke units across the UK. We aim to leave plenty of time for discussion, so please do submit questions throughout the session using the comments functionality on the right of your screen. So let's make a start, and over to you, Rob.
Hello, everybody. Perhaps I'd like to start by sharing these quotes that came from the initial interviews that we conducted with stroke survivors and caregivers. The selected quotes, which are on the screen, capture themes that came up time and time again. You may recognise some yourself. To us, they signify that there is a gap that might be quite large between what the clinical teams think they are providing in the way of support and information post-stroke and what stroke survivors, their caregivers and their families actually need. Each demonstrates that there is not at present an established system within stroke care that promotes easy access to tailored information. Next slide, please. In part, this is caused by the way we work as clinicians, I think. There is so much focus on finding medical explanation for what has happened and how it should be treated that there can often be no time left to properly explain everything to patients and their families. It's not just about time pressure though. There is also a lack of personalised information needed to underpin these explanations. Each stroke is a unique event in terms of the damage within the brain itself, but also in terms of the person this has happened to, their pre-stroke life and their aspirations and their successes and challenges in dealing with the new life that follows the stroke. To explain what has happened and what will happen next with respect to symptoms and treatment and recovery actually requires dedicated time and access to bespoke information relevant to each patient and their family. It's simply not possible at present for us to provide all this information, so in a sense clinicians are set up to fail. The result is too often that stroke survivors and caregivers are left to feel that they need to navigate themselves through the challenges of the new life after stroke. New slide. This was one of the key motivations for us to build My Stroke Companion, so that we have a system that helps clinicians to give the right information to patients and carers. In planning the design, we recognise that the clinicians want to be able to easily provide information that is accurate, up-to-date, tailored and relevant, meaningful to each patient as well as their carers, will reach everyone, particularly the underrepresented groups that can be often lost to follow-up in clinical practice, so that everyone has what they need to make the best recovery and to access their local resources that exist. As a team, including doctors, nurses and therapists, we also need to be able to prescribe the correct information easily and as part of routine work. Finally, we recognise that it's important for us that we are able to be part of a two-way system so that we can provide information but also hear back from patients and carers about compliance, lifestyle and participation. I'm now pleased to hand over to Lee, who will be able to give you his perspective as a stroke survivor.
Thank you, Rob. So my name's Lee Callaghan. My day job is a corporate lawyer for Aviva, where I've been for the last 20 years looking after their international markets. The picture that you're looking at is my brain on the 23rd of March in 2014. I'd been travelling the week before. I got back looking forward to the weekend, and there I am in the shower in the morning on the Saturday, and very high-pitched tone, sudden loss of feeling on the right side, and obviously for the clinicians on, you can see the corona on the left side is obviously being impacted at that very moment. I sit on the Stroke Voices steering co, looking at patient voices and views in research. I also sit on a number of different panels that look at funding for different initiatives. And the overriding point that I just wanted to bring out today is that obviously every stroke is different. That particular gap that you can see on the photograph could be anywhere in the brain. It then has different impacts, different consequences. Everybody is unique as a result. And it often means clearly that their recovery will be different. The strain on their caregivers will be impacted as a result. The challenges that they then face in that recovery won't be linear. They'll all be different. And they'll need support and interaction both from caregivers, but from other specialists, including GPs. And in my case, I do remember trying to go back to my GP a couple of times to talk about medication, to talk about other things that might be impacting as a result. And those are difficult conversations to have in the moment. And often you're talking to people who won't have sufficient detailed knowledge around stroke recovery. Often patients come up with questions around their medication. Do they stay on the medicine they've been given? Should it change? They've suddenly had pins and needles arrive in the other side of the body, for example. Is that significant? The other point that I found back in 2014 was that the information available was good, certainly from the Stroke Association, but it could have been so much better. It's improved a lot since, but certainly access to that information was difficult. You were essentially, as you recovered, were doing your own research. You were relying on friends and family to find out things for you, because no patient will be a specialist and expert in stroke impact and recovery at the time. And the materials that were available were difficult essentially to navigate, not least because of the fatigue that stroke causes patients and the significant impact it has at home. I remember the local authority coming round on the day of discharge 3 days later. In fact, Rob's team had treated me at UCL fantastically, and I was, as with all stroke patients, on recovery within 3 days and discharged. But they were clearly doing an assessment of whether you can essentially climb stairs and make tea. That's really the test they use to see if patients are safe at home. And these are people that are looking after all sorts of other patients being discharged back into the community, not just stroke patients. And they're under lots of pressure, and it is obviously postcode lottery around whether you get that visit at the time or they can come back for a couple of visits to see if you're still okay. That is clearly hit and miss. It depends where you live. It depends whether you've got the ability to interact with them at the time. Depends who's at home. And just those simple things around how do you navigate the home environment with a stroke become really problematic. So the point that stands out for me on my stroke companion, where I've taken on the role as patient advisor, is just the focused attention to individual patient needs. The ability of those dealing with patients to interact with a platform that just hasn't been available before, and it will contain the information that both stroke survivors and their caregivers can access. And that's really significant. It really moves on the debate around how best to care for those recovering from stroke. Thank you.
So at UCLH, we've worked with cognizant and patients and their carers to develop My Stroke Companion. And there are really two sides to My Stroke Companion. This slide shows the main resource, which is what stroke survivors and their carers see. The Stroke Companion can be prescribed at the point of discharge and contains tailored information bespoke to each stroke survivor's needs. So the aim of the Stroke Companion is to improve the patient journey after discharge, empowering patients and caregivers to better understand their diagnosis and care plan, and enable people to understand what local support services they can make use of. My Stroke Companion includes 2D and 3D video animations, selected articles relevant to that person's history and event, information about local support networks and services. Content is available in multiple languages, so far English, Hindi, Polish, Bengali, Gujarati, and Turkish, and in language that makes it as easy as possible for people and their carers and stroke survivors to understand. The resources also include curated additional resources from the specialist stroke charities, including the Stroke Association, Headway, and Different Strokes. Next slide, please. There is also the clinician view of My Stroke Companion, which is designed to allow as quickly as possible the clinical team to create personalised packages of information and resources for their stroke patients, ideally as part of the routine process of clinical care and discharge from the stroke unit. We created a simple selection menu that allows the clinician to choose resources for each patient based on their diagnosis, care plan, medication, and lifestyle needs. This creates a unique look for the patient for their personalised version of My Stroke Companion. Next slide, please. So these are the 4 key attributes of the tool, the pillars, if you will, of what we think is important about My Stroke Companion. We want it to be personalised to each patient and their stroke and their needs. We want it to be localised in that we want it to provide the right information for where that patient lives, their local pathways and their local network. It must, of course, be always current, up to date with the most recent information and evidence and practice guidelines that are relevant to them. And finally, it has to be accessible for all those who need to use it, in terms of language, in content, and in digital accessibility. I'll now pass over to Daisy, who will share with you the results so far of My Stroke Companion at UCLH.
Thank you, Rob. My Stroke Companion has been in pilot mode since May 2022 and has been viewed by just under 500 stroke survivors, caregivers, and friends and family members. We're seeing great levels of engagement, as you can see from some of the stats here, including an average viewing time of 6 minutes per person and a good depth of engagement across all of the resources within My Stroke Companion. We're conducting ongoing research through a combination of surveys, one-to-one interviews and focus groups to understand the impact that My Stroke Companion has on people's understanding of their condition, their ability and motivation to attend follow-up appointments and to get the best out of their care. So far, we've heard that the tool is helping people to understand what has happened to them, what they can expect to happen next, and how to manage their risk factors at home. Next slide, please. We're now moving into phase 2 of My Stroke Companion with a new version of the tool launching imminently with a number of new features, including enhanced personalisation so that people only view what is important and relevant to them, new topics such as TIA, and tailored information for younger stroke survivors such as returning to work, applying for benefits and managing personal relationships. We're also including an ability to collect and track health data to further tailor resources and support people as they navigate their recovery. Caregivers will receive a version of the tool catering specifically to their needs based on their loved one's diagnosis and follow-up needs. We're looking to understand whether providing clear, reliable and personalised information can improve people's understanding of their diagnosis, their confidence to self-manage and take their medication, and their overall health-related quality of life. We're working with our 5 clinical partners to test the tool within different demographic regions of the UK, offering multiple languages for non-English speakers, and working with local community groups to spread adoption and uptake. We're working extensively with patient groups and advisors to continually adapt the tool and serve the needs of stroke survivors and the wider community long term. Beyond this project, My Stroke Companion will be available on a licence basis to healthcare organisations, and we hope to expand our work to make it available across all stroke units in the UK and eventually beyond. So thank you so much for listening so far. Let's now view a very short 1-minute video as we collate some of your questions and move into a discussion. Thank you. Good. Well, we've had a few questions coming through on the comments area and a few submitted in advance. So thank you, everyone, and please do keep asking away. The first question, and one that we often get actually when talking to people about My Stroke Companion, is how is this different to what already exists? There's plenty of information out on the internet and that's provided to stroke survivors as they leave hospital and is available for them to navigate. So perhaps, Lee, we could start with your perspective on what we're doing here today that's different to what already exists.
Thank you, Daisy. I think that's the point. There's lots of information available. It is overwhelming for patients being discharged. It's certainly overwhelming for caregivers in homes or other environments, those that are trying to access the critical information about their condition, their particular circumstances. And the idea that you go to those like GPs with the ability to access personalised information makes a huge difference to the speed and the accuracy of what's being given back in the moment. There's also the challenge that you're essentially relying on patients to do their own research. They suddenly need to be PhD students in stroke recovery and stroke effects, and that puts additional pressure into a situation that's already difficult, particularly if you're dealing with aged relatives who have suddenly had a stroke, because unlike lots of other conditions, stroke arrives, as in my case, without any warning. There's no sort of heads up, something's coming. I had a medical 2 weeks before and everything was super fine as part of my employer care that they give. So it's just one of those particular outcomes that can really challenge individuals in the moment, and that's why this makes such a big difference.
Thank you, Lee. And perhaps, Rob, you could add your perspective to that. The My Stroke Companion was completely born out of your ideas and how you'd identified this gap for your patients. Maybe you could give your view.
Yes, yes. I think firstly, I'd like to say I don't think it's instead of the information that's out there. I think of My Stroke Companion as a curated set of all of the best of the information that's out there, but with the function of bringing it all together when it's relevant, up to date, current, accurate and local for that particular person and their family. It's doing the job of, for the clinician, of bringing everything together so it's making visible everything that we would like to pass on as information for the stroke survivor, without the task of going out and trying to select what might or might not be relevant, and without leaving the stroke survivor themselves the task of trying to look for it themselves. There is also the time issue, and the time issue is that it would be quite tricky, I think, for clinical teams to try to individually select the bits of information that they want to bring together for people. And this does that. And the last thing that is something that sometimes gets forgotten is quite easily information that my department or other departments might create as the current state of how things work in our system become out of date, and you're constantly trying to update with new resources, new team, new pathways, new evidence. And so it isn't a small thing that my stroke companion will move with the times. It will be able to provide information with up-to-date current guidance, rather than the information that was relevant when we produced that leaflet or when we made that information sheet. So I think those are the reasons why I very much like the concept, emphasizing again that this isn't instead of the information that is already produced to such a high level by all of the agents interested in trying to improve life after stroke. It's about bringing it together, but selecting it as relevant for each person.
Thank you, Rob. And whilst we're with you, maybe you could talk a little bit about our work to really ensure that this is accessible to different groups and that we're not creating something that is inaccessible in any way.
It's the biggest of issues, isn't it? You can create information, but it has to be received and understood and be appropriate for the people it's aimed at. There are two things to this I think are important within My Stroke Companion, and the first is a huge thing. The focus that Cognizant has taken on ensuring that there is a parallel information channel for family and carers, so that as well as the person who has suffered the stroke, there is an accessible, easy to understand set of information for those surrounding people who might be having trouble accessing information. And then after that, there has got to be every attempt to make the information that is directed to the patient to be as accessible in language, accessible in content, accessible in digital technology requirements, so that it gets the message across. And the only way you really can do that, I think, is to work with patient groups and carer groups and test what you're creating so that it's achieving what you are setting out to achieve. I think that's the approach that we've taken. It seems a good approach to me.
Thank you, Rob. So in terms of Nikki's question, thank you, whether this is an app or accessed via the internet. So My Stroke Companion lives within our health information portal called Healthy Note, which is available on web and via app. What we see so far is that most people access it, first of all, on our web platform, which is available on mobiles, tablets and laptops and desktop computers. But then as their engagement grows and they realise this is a tool to support them longer term, they can download the app and make use of additional functionalities such as notifications and reminders to help them to manage their health longer term. We've also had a great question about how people can get involved and whether this is available to other trusts within the pilot stage. So we've got our pilot centres almost up and running for the rest of this year to collect data and really understand the true value that this programme can deliver for stroke survivors and family and caregivers, and importantly to the NHS and the clinical teams. So from January 2024, which will come around incredibly quickly, this will then be available on a licence model once we can really understand that value and how it can fit within different pathways. So far, the bulk of the engagement has been within London, so it's important we understand how it can be deployed in different regions too. Hope that answers that question. So a new one we have now is, given the emphasis on understanding medicines, how is the role of the pharmacist incorporated? So that's a really key point. Thank you, Neil. and to ensure that people are able to get better reviews of their medications, and the broader role the government has to play too. So Rob, perhaps you could pick that one off to start with.
I'm going to start by saying that's a really good question, and my take on My Stroke Companion is it's an evolving tool, and I think what you probably need to do to start with is to create a system that covers all of the topics that are relevant to the patient. So good current descriptions on the medicines that the patients are taking. But in terms of how we develop further the use of medicines and the comparison of different medications and the discussion about the medication-related side effects, all of those, I think, are an opportunity for us to further develop and evolve. Clearly extraordinarily important. I think at the moment, probably My Stroke Companion particularly focuses on getting good descriptions of common medicines and their side effects into the companion, but this is probably a really good further direction. And one of many good further directions that My Stroke Companion could take as it evolves to be the complete thing that answers many questions.
Thank you. And Rob, this is probably another one for you, I'm afraid, but in terms of how we know that patients don't get discharged from hospital and nothing changes, their medication and other things change all the time. So how do we handle that within the tool?
So we have been very keen to make sure that this isn't a static record that simply reflects where the person was at the time of hospital discharge. It has to be updatable. And as Laura asked in her questions, how you update the medicines, but also how you update the care plan, how you update the risk information if more information is identified about the causative factors. The answer is it has to be updatable, and the idea is built into the functionality of My Stroke Companion is the opportunity for clinicians to rewrite the prescription, to update the prescription, to include new guidance about found risk factors, to include information about new medications, or to remove information perhaps about medications no longer taken. It's a living system. I think that's coming back to my previous point. There's no use having a leaflet that's relevant to the time you came home from hospital if that isn't what's relevant to you now. So I hope I've answered with the aspiration for what My Stroke Companion is going to be and has to be.
And it's true, Rob, isn't it, that we're on a journey to make this as easy as possible for the clinical teams to work with, which requires some integration with clinical systems, and there's more work to do to think about how this integrates with primary care, because that's not an easy thing to navigate with the different regions in the UK. But we're making great progress to make sure that we're integrated and that it's as seamless as possible. And that information is updated as patients progress through their pathway. And another question from Laura, thank you, about whether there's an aphasia-friendly version. So My Stroke Companion has got content in lots of different formats, so we're really trying to cater to as many accessibility needs as possible. We've got some quite deep kind of written content for caregivers especially, moving through to really easy read, downloadable PDF contents, some video animations that both have text on screen and voiceovers, and a functionality for text to audio so that people can have information read out to them. So we're expanding those formats all the time.
Daisy, and say, this is critical, isn't it, in terms of the population we're dealing with. The first is to return back to the idea that which is not a small thing, which is to make sure that those around the person with aphasia have a good understanding of what's happening, what aphasia is, why there are problems with communication, and then everything that we're writing for or showing in terms of video content for the patient, we need to keep sense checking with users, and in particular sense checking and clinicians, and sense checking with users and clinicians experienced in dealing with the long-term management of stroke survivors with aphasia.
Thank you. And when we can start to make use of My Stroke Companion, and also tying back to Kath's comment about NHS trusts getting involved. So as I mentioned, this project is underway and it's going really well, and we're collecting lots of data, but we're actively seeking further clinical partners to get involved as well. So we'd be delighted to hear from anyone, especially from the stroke teams and ICB leads that are interested to find out more. And we can share a demo of the tool with you and really talk about how it could be deployed within your region. So yes, please do get in touch with that. And any research that's supporting this approach, Rob, again, probably one for you to answer around that, please.
Not yet, but in fairness, this is still relatively early days. One of the things that we're very keen to examine for is the difference this makes, both in terms of patient experience and patient outcomes once they've been exposed and used the tool. So we need a cohort that will come through that have been onboarded and use the information in My Stroke Companion, and then we need to see how they get on in the months after their stroke. So it's absolutely the focus. At the moment, what we have is page use data and patient feedback based on what they've seen. And that's, of course, very different to something that tells us what difference it makes to life after using the tool.
Thank you. And Lucy, thank you for this comment around accessibility with the technology in particular. We've been conducting very regular user testing with a broad range of groups of patients and caregivers. What we found so far in UCLH that just by inserting a link within the discharge summary is not sufficient, and that it does require some kind of onboarding from the clinical teams or ward volunteers or care coordinators to really help people to get onboarded with this and get the most out of it. But we haven't so far really found that people can't use it. We've got a real focus on usability, especially with people with the different needs that we've talked about today.
Might I add in, we're increasingly finding, aren't we, that there is good value in early contact with people after discharge to check all sorts of things. And we are moving, I think, quite quickly within our system to say that this is also a nice opportunity to introduce the tool. Again, it's been introduced on the ward, but to introduce it in the home, to answer any questions people have with their early access to it, and to perhaps show and unblock any challenges. There is no doubt in my mind that eventually people find it easy to use. But with all things at the moment, people can feel challenged by something new, and we have to make sure that we build in a way of making that sense of challenge as small as possible.
Thank you. And Rob, I think a final one for you, please.
So if this does what we think it will do, its aim will be to say that at the time you are describing what's happened to your patient and why, the fact that they have blood pressure and cholesterol, maybe that they have AF, that they need an anticoagulant, maybe that they need an outpatient test, maybe that they need certain domains of therapy, and that they have certain lifestyle issues to focus on. At the point of writing all those things in a discharge summary, wouldn't it be smart if you could also prescribe the specific information about that in that set of recommendations for the patient captured in one place? And so if we're right in saying that's a good thing, then it saves a vast amount of time, because you need to give the information, but this has a way of bringing it all together. And if we're right in the build in the hospital side, and eventually able to do that just at the point that you are anyway saying that this person has blood pressure and cholesterol and AF, then it will be both important in terms of clinical effectiveness, important in terms of clinical efficiency, and also it will allow it to happen reliably, because you anyway have to specify those factors when you summarize a case, particularly at the time of discharging. So I think it will have a big effect on clinicians and service delivery in terms of effectiveness and efficiency.
Thank you, Rob. And I think that goes some way to answer Amy's question as well about risking clinicians' time to prescribe and update My Stroke Companion. Anything else you'd like to mention?
I think in our presentation we tried to show that there are two sides to this. It is all about improving the experience of life after stroke of stroke survivors, patients, carers and families, but it has to be as effective and efficient as possible for clinicians, otherwise the clinicians won't use it. So we try to emphasize that it's a parallel thing. It has to be right for how it's received by the patient group, but it has to be built in such a way that the things like updating and prescription and accessibility for clinicians have to be as easy and as natural as possible. Otherwise, it's another task. So I think we're trying to emphasize we want it to be as part of normal work as much as possible, so that it happens as part of normal work. And so I hope, to Amy, the answer is that clinicians' therapy time should not be affected. The clinician in the community space will need to spend less time covering stuff that is not therapy related. How do I get this? Where do I do that? Who will call when? How can I, what's important? Will it happen again? And actually, hopefully, spend much more time focusing on delivering therapy. So I hope this takes away a lot of the time that's spent on non-therapy related stuff. And I hope that this will also allow the updating of information when significant changes have happened to the prescription to be as quick and easy as possible.
And just to add to Amy, there's obviously an efficiency across the entire health provision, because you've got patients not having to thrash around and find different questions to ask, or looking for answers from specialists and trying to find outcomes or information that is obviously quite hard for them to find. So there's that beautiful efficiency about directing them into the right place to start with.
Fantastic. Thank you so much, Rob and Lee, for all your contributions today and for articulating everything so well.
Monica.
Yes.
So to me, this works best at a sector level, because this allows you to encapsulate everything that's relevant within that sector. And that comes back to this sense of trying to make this local and relevant to the pathways that exist around the clinical teams and around that particular patient. So if I could choose, I would say this is the kind of system that should be implemented at a sector level, so that it works in the way that our stroke networks work, which are sector wide, rather than something that one hospital does that links out for that hospital, and then another one does in a slightly different way, and another one does in a slightly different way. We're all networked, it's one pathway, and the idea as much as possible is to make it this a tool that is most meaningful as a networked tool.
Fantastic, Rob, thank you. So if anyone would like to find out any more, get in touch to discuss this, then please use the email address here, hello@cognitant.com. We'll make sure it gets to the right person. But thank you for everyone for joining today. I hope that's been an interesting session, and thank you again to Lee and Dr. Simister.